patterns emerge when you treat old groups of people, and one of the things that's very striking is that obvious thing, Darwinian natural selection. Young players who've got any weakness in their makeup, and you'll be well aware of the predisposing factors to anterior knee pain, etc., they'll get found out. They cannot cope with the loading, and if there's any tendency to injury, they'll get it. And so if you get somebody who's about 21 years of age or more in professional sport, they're probably put together right. Now if we take ACL, which is the topic of the talk, it's a rare injury in a first-team player. It really is uncommon. I mean, at Chelsea, they had none for the first 10 years looked after them, and they had 3 in a season. And they've had 1 since in the first team. But every year in the academy, there's 4 or 5. So these young boys, young women who've got a much greater risk of ACL rupture get found out. They also have a higher re-rupture rate, which presumably is because they got this predisposition. I get them back pretty consistently, but they never make it. It's deeply depressing. And there are various reasons for that. A first-team player is on a lot of money, on a long contract. There's a huge vested interest for the club to wait and be patient with and invest the patience in that player. But for a young boy or young woman, they aren't earning money, they're cast aside. And until they're about 18, they're playing year by year age group football. And if you miss the season, you never catch up. So do all ACLs in these guys need surgery? The answer is yes. These guys need an operation. They need to have a stable knee to allow them to get back what they're brilliant at doing and to protect them. There is no place for non-surgical treatment of ACL ruptures in athletes. Don Shelburne, massive name in ACL surgery, really forced changes that made it a repeatably decent operation. One of his biggest things was the idea that you have to wait 3 weeks to let the knee settle. We've moved on from that. Some knees are ready day 1. Some knees take 3 months to settle. But the average for the professional athlete, particularly as they get such good care in the first few days, is around 7 or 10 days post-injury. And when I say the knee is quiet, I mean full active extension. I should emphasize active rather than just passive. I need to be bending freely to about 100 degrees and not much of an effusion. So we've worked out when we're going to do the operation. How are we going to do it? Well, overall my patients, my most commonly used graft is hamstrings. And I use hamstrings on Joe Public. They seem to cope with it very well, perhaps a little better than patellar tendon, and therefore the complication rate's a little higher. So it's lower, sorry. If a patient's still growing, then you can't put bone blocks across the growth plates, they'll stop growing, so you have to use hamstrings. And I like it for jumping sports, because you don't damage the extensor mechanism, and for kneeling sports like judo. It's a sprinter's muscle, the hamstring, but they're still fast after the use of hamstring tendon. I have to say I wouldn't use it on an Olympic type athlete or a para athlete like a rower. And so in rugby, which is a pretty violent sport, you may have noticed, and if you haven't, you will do in the next few weeks, my re-rupture rate's 5.8%, and that's throughout career. But in football, I've looked at my data, professional footballers, they have a double re-rupture rate using hamstrings. Now, that's not to say some of my best ever successes with professional footballers have been with hamstrings. But by getting the data and collecting it, the really annoying truth is that patellar tendon re-rupture is half. And that's backed up by data from Norway and actually in fact Denmark as well. And the Kaiser Permanente group, they're basically like Bupa in America, their data would support less re-rupture. And so in elite sport, failure is not an option. Simon said that earlier on. A bit of anterior knee pain might be. And if you have to have a revision ACL, you're going to miss a second season. That's probably career ending for most people. It is obviously the best graft. Nice bit of tissue, 2 bone blocks on the end of it. It's beautiful. To be fair, of course, that has to be balanced against the morbidity of harvesting it, and there is an increased incidence of anterior knee pain. I'll use a patellar tendon in the normal population if they've got significant MCL laxity when I don't want to touch the medial stabilizers, the hamstrings. If they're really lax, I'll use patellar tendon. if they've got a significant malalignment. Of course, most footballers are in varus. Because the proprioceptive insult of losing your ACL, for many, many months, it's very subtle, but they will, if you look at gait analysis, have a lateral thrust if they've got varus alignment. So if you've got a rather elastic hamstring graft, it's going to stretch up. A more rigid graft probably is a better thing. And obviously you can't use an osteotomy to straighten the knee out. They don't get back to play. Now, the other bit of good news is that a patella tendon ACL these days is nothing like the operation I did in the early 90s. It was shocking. So now all we do is lift the graft off and then do an arthroscopic procedure to insert it. The tools are better. I keep doing this operation. Now, I'm old enough to have seen this as this was how ACLs were done in the 80s. No intra-articular surgery, but a huge slash on the outside of the thigh, an ITB tenodesis. So you take a strip of ITB, centimetre long, leave it attached to Gerdy's tubercle, take it underneath the LCL, and then bolt it onto the femur. Massively powerful way of controlling internal rotation, which is what the deficit is from an ACL deficient knee. The pivot shift is an internal rotation phenomenon. And on the MRI, you can see what we get. We end up with an ACL on the lateral side of the knee. Well, that's not a bad thing. If you're trying to drive a racing car, it's exhausting because you've got incredible control, but you've got to hold it like hell. If you're on a ship, you've got tremendous leverage. And so if you've got a band of tissue oriented like an ACL at the periphery, the lever arm to control rotation is massive. And the logic is that that will protect the ACL during healing and is an extra restraint against the pivot shift when you get back to play. So maybe not a bad thing. And we've been looking in the lab at Imperial College, and there's a lot of hype about something called the anterolateral ligament. We were one of the first groups to describe it, and I fell in the trap of thinking it was important. It's not. It's a small piece of gristle you can't always find, and really is not very important. But what is important is the ITB, and it's got some extensions onto the femur, and it has a great role in controlling rotation. So you will have noticed that increasingly people are doing tenodesis. I certainly am. And maybe for the sportsman it's not a bad thing to do, but it does add morbidity, and I don't suppose it's necessary in every case. So when do I use it? I use it in every revision case I do, and also if I'm basically worried about the patient. They're very loose, so they've got a lot of adverse alignment. Now, what about the post-operative phase? Well, you've got to get a good start. That's where your anaesthetist comes in. So I tend to work with 1.5 anaesthetists. The half comes every now and again. She's brilliant. But they've got to understand pain relief. So when the patient wakes up, they can start moving the limb. With athletes, you don't kick them out home. You keep them for a long time. They don't do pain, particularly rugby players, and so you can't trust them. And sometimes they go home to very unsuitable environments. The youngsters particularly are in digs. They've got somebody who's nice, good at making a cup of tea for them, and that's about it. You really want to make sure that it's going to go well. I don't like phone calls, and so isometric quads are really, really key thing early on. You can buy time with passive work, stretches, prone hangs, etc., but the active contraction is critical. Swelling is your number one enemy. I'm certain that there's a genetic predisposition, just as we're all destined to have different immunity. I'm Mr. Allergic, I've got a bunged up nose now. Other people don't get that. I scar very badly. I'm sure there's a gene for swelling. And if you're unlucky enough to have a sweller, and those who dealt with athletes, it's a nightmare, because it's going to take twice as long as anybody else, and nobody can wait. They want to know, why am I slower? We just are. Sometimes you have to make that clear. With the rehab, again, from experience dealing with people, you've got to go long. I mentioned that early on, but you can't mention it too often. And in Aussie rules in Melbourne, friends of mine who work there have now insisted on a minimum return to play of 9 months, because the re-rupture rate around 6 months is too high. There's incredible pressure. Why would I not embrace the rehab? Why would I not communicate with physiotherapists? After all, the people are going to make me look good. You could make me look like a monkey if I don't talk to you. So we've got to build up a relationship and trust. And I've learned immensely from that relationship. Some of my teachers are here tonight. And I want to be not exactly controlling things, but I want to be knowing what's going on. I've got a nervous sort of habit of ringing people up sometimes. What about return to play? Well, first of all, they're going to be fit. If not aerobically fit, they'll stick their leg out in exhaustion and pop the ACL again. Patients going to be able to trust their knee. The difficulty with that is athletes can get their minds over things, so I don't really trust that. But if they say they don't trust the knee, I really listen. I want a dry knee. If fusion is bad juju, if you've got swelling in your knee is not coping with the loading it's under. But if there's swelling, it means they're not ready, probably in terms of neuromuscular control. And then there's a magic thing, symmetry, by which I mean they've got to be strong. So if you do isokinetic testing with its flaws, you want to be within 10%. If you do functional testing within 10% on hop height, hop distance, all the other tests you want to do, when the coaches are looking at them run, looking at them twist and turn, when the player's thinking about which side they prefer to turn off, it's got to be equal, because if it's not, they're not ready. And you want a minimum of 6 to 9 months after surgery. And the horrible truth is the knee will improve, I reckon, for a minimum of 18 months, possibly 2 years. And the first season back, the players doing their final rehab, they're relearning to do those amazing things that I've never been able to do. But if you've got somebody with a big lesion on the joint surface, significant meniscal pathology, or a sweller, the swellers we almost always get right in the end, but the chondral damage can be career end. Patellar tendon is the best graft for football. Resist the advice of the non-medical medical experts and go slow. Get it right first time, because as the financial director of one of the clubs I dealt with when we were about to sign the biggest signing in British history said, Andy, it's your cock on the block.